My name is Tracy Berardi, Program Manager of BPM Health. This is our fourth session of a two-day virtual event. And before we get started, just as context for those of you who may be new to BPM Health, we launched the BPM Health community back in September 2019. And this is a community initiative to improve the quality and consistency of healthcare delivery. Our focus specifically is on using open IT standards. These are business process and case modeling standards to formally model clinical pathways, clinical guidelines, and other healthcare knowledge to make this knowledge computer consumable and in the future automatable. Professional education. So this is where the work is done, and the sessions that you are attending today and also yesterday map back to work that's being done in these groups. So everyone on the call, if you're interested in joining as a member and getting involved, it's bpm-plus.org, and there's a membership and participation page. So today's session, our first for today, from evidence to encounter accelerating clinical quality, is with Mr. Ken Rubin, U.S. Department of Veterans Affairs and the community convener, BPM Plus, and Dr. Pawan Goyal, Associate Executive Director with the American College of Emergency Physicians. I'm going to go ahead and turn this over in just a second. I do want to mention in the chat box and GoToWebinar, there's a link to our site. This is where you can find the schedule of our event. There's 5 sessions that we're doing today. This is the first. So all this afternoon, we've got back-to-back events, some great sessions. We're also posting the presentation slides and video recordings. So check back later today. And if you have questions, go ahead and enter those in the questions tab. We'll have time at the end to address those. But Ken, it's over to you.
Thanks, Tracy, and good morning or afternoon, everybody. We appreciate your making time today to be with us. So what I'd like to do is talk a little bit about really the business case behind the business process management, Plus Health community. I wear a couple of different hats. One, as Tracy alluded to, is as convener of the community for BPM Plus, and the other is with the VA, where I'm the Director of Standards under their Office of Knowledge-Based Systems, and that's the hat I'd like to really start off with as we talk to kind of the VA as an organization and why it is that we're interested in this and what we're trying to accomplish, and then relate that to kind of the broader context, and then we'll bring Pawan in, looking at this from a clinical professional society and clinical quality point of view. So hopefully before the session is over, we've given you some context for really understanding what this is all about and why it's important and why the timing is right to really move this agenda forward within the industry. Tracy's going to manage the slides for us, so if I could ask her to advance the next slide, please. Again, this is based on sessions that we'd hoped to deliver at HIMSS. We're certainly disappointed that the HIMSS conference didn't happen as scheduled, but certainly the group made the right call, and our hearts go out to everybody who's dealing with the coronavirus circumstances at the moment. In terms of conflict of interest, neither Pawan nor I have any apparent conflicts of interest. Let's go ahead and move on, please. So the agenda we want to set up, first, talk a little bit about the VA in the business context. There was an effort this past summer under the Agency for Healthcare Research and Quality looking at evidence-based care. So we'll talk just a little bit about that and how that relates to this broader agenda, and then specifically drill down into that in terms of pain points and opportunities that are presented to advance clinical care and why this relates to BPM Plus. If we could go ahead and move on. So the learning objectives, I'll just just leave this here. Hopefully this is for folks that want to do more detailed study on their own, but it's available in the deck. And a lot of the slides we've included in the deck for more robust coverage, but we'll cherry pick some of those in the discussions today. So if we could move to the next slide, please. So about the VA, I see that there are several folks on the line from VA, and for those that may not be familiar, the VA is the largest healthcare provider in the United States. I'm not going to go through all these numbers. These are based on a scan that I did about 2 months ago, and then the latest available public data. But I think the kind of key takeaways is about 9 million beneficiaries actively receiving care in the VA. That was as of 2016, which was the last year for which public numbers were available. And we run about 1,500 points of care. That includes everything from small community clinics to major metropolitan hospitals. We operate approximately 170 hospitals. And for me, the two numbers that really stand out, one is the top of the second column there. 65% of the physicians in the United States did some portion of their training at the VA, which is just a massive outreach. And that we're affiliated with 144 of 152 accredited medical schools in the U.S. So VA has a tremendous, research mission and educational mission in addition to the operational component of actually caring for the veterans and those who put themselves in harm's way for our behalf. If we can move to the next slide, please. So how does that relate to clinical quality and this broader standards effort? So veterans receive care at the VA. A lot of veterans, many veterans, and one could argue most veterans receive care at some portions outside of the VA. So it's our job not only to look after veteran care when they walk through our doors, but to look after those veterans that might never walk through our doors, or those that only elect to walk through our doors to receive medications, or for a specific disease condition. Perhaps it's mental health, perhaps it's prosthetics, whatever the case might be. We are in the midst of, and that number is certain to change. I think it's already changing, a $16 billion modernization of our electronic health record system that's going to be happening over 10 years. So we're partnered with Cerner in advancing that. I know there's work heavily going underway as we speak to institute that. This modernization effort is not going to happen overnight. It's going to be a phased transition over a long period of time. And throughout that period, not only do we need to provide care at the sites that have switched over to the new system, but what about all the sites that are running the old system? And what about veterans that are receiving care in multiple places? And not all those places are in the VA. So that creates some huge quality challenges and care delivery challenges as we look to basically have the care support the patient wherever they elect to receive their care. And that really starts to set the backdrop for why shareable pathways and shareable workflows are important, because it's not a matter of getting one point of care, one setting perfectly implemented, deployed, et cetera, but rather supporting that care wherever the veteran chooses to receive that care and across the whole of their care experience. If we could move to the next slide. So what are some of our challenges and priorities? Well, and I'm not going to go through this whole list, but for instance, I think that the top one is very important. Clinical best practices are changing all the time. So let's say a new stroke protocol guideline comes out, or a new emergency care guideline comes out, or the guidance around coronavirus. How do you deal with that? How do you bring that into the institution? How do you support that within your IT? How do you deploy that? And then, equally important, how do you change and adapt when those things change? And it's not just one guideline, it's hundreds or thousands of guidelines. And we don't have just one facility to worry about or one department to worry about. I've got thousands of facilities and tens of thousands of departments, all of which are just within our own institution. And that's not everywhere veterans are being seen. So the challenge of keeping pace with all of these moving targets is tremendous. And that stems beyond just data interoperability. So if I leave you with one takeaway from today's talk, data interoperability is hugely important. Getting the right data to the right people at the right time for those that are authorized to see it. That's a key enabler that's essential for everything that we're trying to do. but a lot of folks focus on interoperability exclusively at that level, and that's not enough. So just having the data there doesn't mean that that data is actionable, useful, timely, et cetera. So there's a lot more that goes into it, and how does that inform the clinical process to help a patient, achieve their personal goals and keep them well and maintain alignment with what is good practice. And that's really what this effort is about. If we can move to the next slide, please. So ultimately, go ahead and scroll back one. So why can't best practices follow the patient through their journey of care? And that's really the enabler that we're getting at, is we want not only the data, but the clinical processes, the workflows, the processes, the pathways to follow that patient as they traverse sites of care, as they traverse institutions of care in their journey to wellness or care improvement. Next, please. So go ahead and click 4 times. Yeah, just go ahead and build it all. Yeah, thank you. So I mentioned this AHRQ initiative. It's the worst acronym known to mankind. It stands for the ARC Evidence-Based Care Transformation and Support Effort. And what ARC was looking at, in effect, and this was an effort that ran for better than 6 months, en route to establishing a set of recommendations to HHS and the nation about how, as a vertical industry, how as a market sector, we can improve evidence-based care, improve the delivery of care, improve our ability to consume evidence, bring it to the appropriate point of care, and have that positively impact patient interactions, with their care teams. And in effect, it took on 4 kind of sub areas. And there were some key findings here. One is that a lot of that evidence is out there today, but it's not being used as effectively as it could or should be. That we need to establish this kind of virtuous learning cycle, not only applying evidence-based care when and where it's needed, but figuring out how effective that has been, learning from those lessons in terms of real-world use of that knowledge, and then evolving not only our understanding of the knowledge, but how it's used to improve care and wellness. We want to empower what ARC calls the quadruple aim. This is not a new acronym for many of us, but for some of us it might be. Improving health, improving the overall patient experience, improving the physician's life, and by physician I use that probably incorrectly. I really mean all care team members, everyone involved in the clinical process. So how do we improve their experience? And then, all of this cognizant of cost. And if we can hit all 4 of those things, then it's a win all the way around, especially, for the patient. The way that ARC took this on was to create a set of work groups. I'm not going to walk through all of those work groups now. I will mention that I was co-chairing the infrastructure and standards work group, which was in part looking at what assets were out there, how they were represented, where there were pockets of this knowledge, and how well as an industry these pieces fit together. Okay, if we can move to the next slide, please. So I'd like to wrap my portion of this before we hand it off to Pawan with kind of a glimpse into the future. So what might the next phase look like? So what we want is not clinical guidelines, best practices that come out as 400-page documents that then get distributed among healthcare organizations and IT vendors that now need to parse that, which requires technical expertise, it requires functional expertise, it requires health informatics experience to interpret that guidance, figure out how it's going to be employed, how that manifests in IT, change our systems to be able to support those requirements, deploy those into our organizations, change the way we practice medicine to support these new guidance. So we have an organizational change component, et cetera. That whole process today takes years. Wouldn't it be nice if, as new guidance comes out, it's in a format that machines can just directly import and configure? So instead of a PDF document, we're distributing something executable that an EHR vendor, for instance, could import into their system, map to data sources, map to order sets, and then basically put us, years ahead of where we are today. So now the organization then has they still have to determine exactly how they want to configure it within their sites of care, and how they want to deploy this, and what process changes they're gonna institute within their organization. But in effect, we've taken all the technical latency out of that problem. This also puts us in a position where patients with comorbidities with differing guidance can start to identify that, potentially using mechanisms like AI to start to identify where we have conflicting guidance, so that the care team can intervene and make appropriate decisions on behalf of the patients. So I think these are all things that are enabled. If we can get to a point where we're starting as an industry to share formalisms in terms of how this knowledge is expressed, how it gets consumed in the IT, and then ultimately how we deploy that out into health systems and not just IT systems. So with that, what I'd like to do is pass the baton over to Pawan. And if we could advance to the next slide, please. And let him give you a point of view from the American College of Emergency Physicians. So Pawan, over to you.
Thanks, Ken, and good morning, good afternoon, everyone. First of all, I want to thank all of you for joining this webinar. Also, at the outset, would like to thank some of our volunteer leaders who have helped us with some of the modeling effort. And I would like to share some names here. First is Dr. Jim McClay, who is Professor of Emergency Medicine and Informatics at University of Nebraska. He has been the business champion of this effort with OMG from ASAP perspective. We have Dr. Susan Proms and Dr. Sigrid Han, who have been our subject matter expert for the first trimester bleeding modeling initiative. And then we have Dr. Alexis Lepitra and Dr. Rubin, who have been the subject matter expert for the back pain initiative. We couldn't do our modeling initiative without their expertise, and we look forward to working with them more. So a little bit about ASAP. ASAP is a physician society for emergency medicine for emergency physicians. There are 40,000 plus emergency physicians who are active members of ASAP. ASAP has started to focus on quality programs as our mission is to further the quality of care in emergency medicine, as well as being an effective advocate for the patients, communities, and physicians that serve those communities. So within our quality program umbrella, there are a few focus areas. One of them is data systems or data science division, which we call Clinical Emergency Data Registry or CEDAR, which is an effort that is collecting data from various emergency departments to create various national level baselines and benchmarks and understand the variability into care. The second program is the Emergency Quality Network, which is our quality improvement initiative. Based upon our learning and the variability from CEDAR data, we put together programs on wherever variability exists, and there are opportunities to build consistency and standardization. So we build toolkits and education material for dissemination to the care providers in emergency department through eQual. Our third area is the measurement science division, which we call quality measures. And this is what to measure, how to measure, and why it's important to measure. Because if we cannot measure, we cannot improve. So that's the philosophy used. Next slide, please. Then we have a couple of other areas. One of them is the data analytics platform, where we are looking into data from our first three initiatives and trying to move into the next generation areas, such as that data into artificial intelligence and predictive modeling to further the research in medical education. As Ken said, how good it would be if we can take the available information and then automate the application of that knowledge into various workflows and downstream systems. So that's the focus of data analytics platform. And the last area is the health information technology. And we are very excited for our collaboration with OMG and HL7 into our health information technology, which is applying the knowledge and the creation of clinical policies and workflow into various digital solutions and platform, especially into EHR platform and some of the VA systems that Ken talked about. So let's move to the next slide. So what was the business driver for ACEP to participate and collaborate with OMG on the initiative for BPM Plus? So in the 5,000 plus emergency departments that exist in the nation, there are 150 million emergency visits that happen every year. So almost 40% of US population at some point in time has an encounter in the emergency department. And as Ken mentioned, there are 9 million veterans. A lot of veterans go to emergency department in private sector as well. So how do we coordinate their care with various primary care providers and their final home, which is VA for most of our veterans? They come back to VA for their care. How do we provide them details and get information from them when a patient arrives into emergency department? Our care providers have to create a care record from the scratch. They have to know about their disease conditions, their allergies, their current medications, past medical and social history, etc. Well, how good it would be if we have that information available through various information sharing and interoperability from VA and other areas from those patients are coming from. And once the patient is stabilized and the care has been provided, how can we give back a summary to the care provider who will be transitioning the care for those patients? So that's one of the challenges that we have in emergency department, that most of the patients that come to us are unknown to the system, and we need to have that knowledge capture. The second challenge is the variability in the care pattern in emergency department. So most of the emergency departments track their performance and they have quality measurement and outcome that they track. A lot of that tracking is on the operational side, such as door to dock time, or the throughput time, when did the patient arrive, when did the patient leave, or what is the wait time in the emergency department. But there is little knowledge that is available around clinical care of the episode. Why, what did we do when the patient came, and what are the top reasons why patients are coming to us? So understanding those variability and then addressing that variability is a key important factor. The data discovery burden is huge on the emergency physician and care provider. As I mentioned, we have to collect that information before we arrive at a differential diagnosis and decide what procedures we need to do or what test we need to order on these patients. And then the EHR workflow design does not help the emergency physicians. A lot of emergency physicians, when they receive a patient, if patient is unknown, they have to create the care episode or collect the demographic and past information for the patient. If patient is known to the system, they have to address a lot of primary care alerts and reminders. If a patient happens to be a diabetic, they have to go through a series of reminders about their foot examination, about need for their flu shot or missing their eye exam, which may not be relevant when patient has an emergency. So how do we create a workflow design that is sustainable and more user-friendly for emergency physician? Let's move to the next slide, please. So there are certainly opportunities for digital transformation in emergency medicine. And we are looking into those opportunities as we are working with OMG. Some of them is the resource management and information flow. So on an average, an emergency physician takes care of certain number of patients in their 12-hour visit, 12-hour shift. And in that 12-hour shift, they could be taking care of 15 patient, 20 patient, 25 patient, which means there is limited time available for each patient. And resource management becomes extremely important. Not only it's the manpower resources, but the availability of the room, availability of bed, and the availability of equipment, etc. And if they spend a lot of time figuring out the information and then synthesizing that information before they could serve that information, things slow down. So slowdown in emergency department is an important aspect that could be managed through these modeling initiatives. Other is the automation of successfully managing the patient flow. The patient flow is also extremely important. For example, an average patient that gets discharged from an emergency department spends 3 hours in an emergency department. If a decision to admit is made, the patient would spend another 3 hours waiting for a bed to be available. So during those 6 hours, a lot of things can happen, and there could be critical need from the patient perspective. Another thing we are observing in our data collection, that out of those 6 or 3 hours, approximately 2 hours and 30 minutes is spent in ordering tests and getting results of those tests. So how can we automate some of those workflows? So that's another goal for us in the BPM modeling initiative. And the other important aspect is how can the emergency physicians use those models and get access to the data quickly and reduce physician burden. So several surveys has been done on the physician burden. That's an important aspect in the House of Medicine right now. And most of those surveys show that the number one reason for physician burnout is the administrative burden. And within administrative burden, the top subcategory is the clunkiness or non-usability of EHR. How do we help those EHR to be designed better for physician workflow, not only for emergency medicine, but overall for the entire House of Medicine? Next slide, please.
Okay. And Pawan, just a time check. We have about 20 or so minutes.
Sure. Thank you. Appreciate it.
Oh, you're welcome.
So as we started to look into model, what are some of the basic requirements for BPM plus model? Certainly, we want to look at the model which is both human readable as well as machine consumable. We want to have a broad appeal. We want those models to be more patient-centric and not so much specialty-centric or physician-centric. There has to be a defined scope for the model where we have the input and output criteria as well as the logic that can handle the inclusion and exclusion criteria. It has to be market viable. When we build these models, they should be consumable not only by the EHR companies, but other consumers that are building various devices in the healthcare. And then all the best practices and policies should be available and consumable and automated in consumption of those models. And finally, it's the scalability and adoption of those models at a macro level. Next slide, please. So we looked at various models within the BPM Plus, and Ken will address some of these in the future slides. So there were 3 models, BPMN, CMMN, and DMN, that we will be using in building of these models. Next slide, please. So from society perspective, what did we need, for our success? So certainly we need certain use cases that are based upon best practices and clinical practice guidelines that are stable. We needed at least 2 to 3 subject matter experts to work with the modelers. We needed to create BPMN workflow, and then also look into some of the unstructured work, especially in emergency medicine. 60 to 80% of the data that flows through is into textual. So we needed to have some kind of interpretation of textual data mining. And then also look into the various output in terms of differential diagnosis, and then series of tests and procedures. In emergency medicine, one of our focus is to stabilize the patient and then move the patient to a final home where their final care will be taking. And then within the stabilization process, we start with some basic tests and procedures. And based upon the impact, then we look into the second or the third step. And that is very important from DMN perspective. Next slide, please. So the role of SMEs is extremely important, as well as the role of guideline and the tooling that is required for the 3 modeling initiatives that are required. We had to put together a project plan and then have a project manager to help us keeping everything aligned. Next slide, please. Those are important considerations from investment perspective before we start any project. We did look into 2 use cases. One of them was the management of low back pain patient in the emergency department. And as you will see that every patient that comes, we have to do history taking and we have to do full physical exam, and then we have to do a very focused exam for the low backache to arrive at various differential diagnoses. And the differential diagnosis on the right hand side could have multiple conditions. There could be neurological condition, there could be musculoskeletal or congenital or infectious diseases. And we decided to look into one of the differential diagnoses. Let's move to the next slide from BPMN notation, and which was the musculoskeletal pain. And we had to go through a workflow evaluation. And those of you who are familiar with BPN, you see there are arrows that flow into one direction, and then they come back, and then there are several decision points with that the diamond tree demonstrate. So it's very important to have a common understanding of those various pathways and sub-pathways that could happen as we build a machine consumable model. Next slide, please. And based upon the model that we pick, we look into the first line of treatment and what to administer to the patient and what are the various options that are available to the patient. Next slide, please. Once we have consumed the first line treatment and patient had limited benefit, then we look into the second line of treatment and various protocols that are part of our clinical policies that are applied here, which could be the next generation of treatment, and then understanding what are the benefits to the patient for the second line of treatment. Next slide, please. And then we look into the various recommendations. If patient is being discharged after second line treatment, what are the recommendations that become part of the discharge planning process for this patient? It's important to have an identifier assigned for each of the procedure or product or recommendation that is applied in order for it to become machine consumable. Next slide, please. One of the challenge that we are trying to address in the low back pain is the reduction of opioid usage for low back pain, and what are the alternate therapies that are available, which is important for patient education perspective as well as the discharge instruction perspective. Next slide, please. The second area we focused on was the first trimester bleeding. And that is still in development in terms of our future protocol and machine learning point of view, how to create a stabilized episode for the patient and then refer that patient back to either primary care or their gynecologist. There are various alternatives that are being built, and that will be part of our phase 2 journey. And we will be also looking into another use case moving forward, which could potentially be the diabetes care, why patients are coming to emergency department with uncontrolled diabetes or complication of diabetes. Next slide, please. So let me bring back Ken to talk about overall value and where do we go from here. So Ken, over to you.
Thanks, Pawan. And by the way, I would like to draw attention to the questions box. So we're gonna wrap up this portion in just a moment and have a few moments for questions. So if you have any questions, please post those in the question box. So what is the overall value? I think the opportunity here is to start to advance consistency and care quality across these how am I going to say this? Whenever you have a care handoff, there's an opportunity for something to fall down. And that's where gaps exist. That could be between specialties, it could be between referrals, it could be across sites of care, et cetera. Sometimes it's a gap in understanding between a care team and the individual subject of care. So I think the opportunity here is to start to target those areas with these workflows to more seamlessly support those transitions. Identify areas where we have poor health outcomes and establish processes to advance those. If we can move to the next slide, please. So this really brings us around to introducing BPM Plus as an effort. So this is a community of practice. That's being stewarded by the Object Management Group. It's an open community. It's a nonprofit organization, and the idea here is to use open standards-based expressions and promote the use of commercially available tools to be able to express these pathways in such a way that allows for a lot of the objectives that we've just talked about. We officially launched in September 2019, so officially we're not that old yet, and we're pleased to have received endorsements and support from several key industry players, including HIMSS, HL7, NCQA, ARC, and others. If we could move to the next slide, please. So as a community, we're really about improving the quality and consistency of this healthcare delivery through the use of open standards, really in this process space. So I alluded before that the data interoperability isn't enough. As a community, we're really focused on this notion of process interoperability and everything that entails, from institution all the way through to product vendor. And the community is very diverse. So we've got a broad cross-section of the industry already playing. You'll see that more in just a moment. If we could move on, please. So I think we've covered this slide in the interest of time. I want to get to the questions, so we'll skip that. So what is the structure of the community? We've organized around, and Tracy alluded to this in the beginning, we've got 5 focus areas. One is around the authoring, so clinical professional societies or healthcare institutions that are producing guidance would fit within that particular swim lane. The second community is around institutional adoption. How do I take these care practices and actually put them into care settings and use in delivery? We focus on the clinical side, but we're not limited to clinical. So this might be administrative processes, end-to-end scheduling, et cetera. All fits within the realm of BPM Plus. The next kind of group is the implementers, people that actually try to go make this stuff work in software. The fourth subcommunity is the methodologists, the people looking at the core notations and what those languages are and making sure they're fit for purpose, and if we have gaps, closing those gaps so that we can still all do this with a standard stack. And then the last area, which we're just launching now, is around academic and professional education. So working with medical schools to advance curricula around this, to bring it into informatics programs, as well as continuing education for subject matter experts like you find in professional societies and other institutions. If we can move on. So finally, the state of things. As I mentioned, we launched officially in September. We're still in the honeymoon period. Not every I is dotted or T is crossed. That a lot of those policies and procedures are coming into place now. We've made public commitments that we'll have those ducks in a row by September. At the moment, we've got about 30 organizational members. Membership is organizationally based, so one member, for instance, the VA is one of those members. We have an established ambassador program, so we've got folks that are willing to put aside their day job hat and put on a community hat and have conversations, representing the community and what we're trying to do, and work with you and your organizations to understand the value proposition and how we might collaborate together. There's work underway around collaborative tooling and infrastructure. One of the things that will be announced probably today or tomorrow is that we will be having a virtual workshop, an actual kind of more than just presentations, but an actual roll up the sleeves, working set of sessions in about 2 weeks. So we're heavy in the planning for that. That had been a face-to-face event that, given the current global circumstances, is being commuted to a virtual event. So there'll be opportunities for folks to start to roll up their sleeves and get involved with that. If we can move to the next slide, please, and then we're just about ready to move on to questions. So the art of the possible is, at the moment, when you have a paper document, you can't really simulate its behavior. You can't figure out how different guidance interacts with one another. It's very difficult to address patients with comorbidities. I think the art of the possible is starting to computer enable those things. So not only making this guidance and these evidence-based practices easier to consume, but start to figure out the interactions among them and how does that affect decision support, and how do we bring that into the hands of not only the care team but the individuals themselves so they can make more appropriate, accurate, timely decisions based upon what the current state of the practice is. So this is really all where we're heading. We certainly would love to have you get involved with us, at the website, and Tracy will leave you that in just a moment. Certainly, there's opportunities for you to sign up for the specific lists. You don't need to be a community member to start to contribute on an individual basis. Certainly, we'd love to have you join formally, but that's not a barrier to starting to get involved. So please do get involved, and this is our contact details. And why don't I pass it back to Tracy so we have saved at least a few minutes for Q&A.
Sure. Thanks, Ken and Pawan. We do have a question here. Does BPM Plus Health support / enable a care standard across geographical areas, rural, urban? A consumer should expect the same level of care, right? Especially in an environment of virtual health, robotics, and shareable best practices. Any thoughts on that?
Pawan, do you want to lead that off? You're the physician in the room.
Certainly, I agree. As we are building these models, we want them to be product neutral and enabling all kind of capabilities wherever they can be consumed. And the consumer could be not only EHR, but various devices and various virtual systems. But we have to go through extensive testing, and we need robust use cases that are cross-functional. So that has been the focus. And from standards perspective, Ken, if you want to add anything else, please do.
I think you nailed it. As we develop this guidance, and one of the things we didn't talk to, and it came up as a question on one of the webinars yesterday, so I'd like to raise it, is the question of intellectual property. So as a community, BPM Plus is not producing any models. We're producing the formalisms that organizations can use to produce models. So it's up to organizations that are authoring content to determine, how they want to distribute that, if that's a free good or if that's a fee-for-service item, et cetera. But we're not trying to be the authority on the content of the models. We expect professional societies and healthcare institutions to be the ones doing that. But what we want to do is to remove, present-day barriers that adversely affect the effective sharing of those models. And I think that gets right to the heart of the question, which is, at the point we've done that, care can more effectively flow, from, perhaps a surgery in a metropolitan area to long-term care in a rural community, with all of that context and appropriate, workflow passing along with the patient as they transition. So I think this idea of seamless care is very important, and certainly one of our principal aims.
Great. Thank you, guys. And I'm just going to take this moment here too. I just had pause screen. I'm just pulling up the BPM Plus website, and I'll reshare. We got to all of the questions. That's great. Okay, so now you should see. So this is our home base at bpm-plus.org. We encourage you, if you're interested in getting involved, Ken mentioned we'll have a working meeting in just a couple weeks. You can visit our site here under Join BPM Plus Health. There's a membership tab with options to join under your organization or as an individual participant. And then under Participate is where you'll find our working group meetings. And again, later today, we're capturing the presentations from today on our site. That link is in the chat box. You can also find it here under Events. And if you have some time this afternoon, check back. We have 4 more sessions and demos coming up today. But thanks again, Ken and Pawan and everyone that dialed in. Hope to see you again soon.